Hello, everyone. Welcome to today's Better Care Playbook webinar on how the Camden Coalition is applying research lessons to improve care delivery. This webinar is made possible through the support of the Seven Foundation Collaborative. My name is Logan Kelly. I'm a Senior Program Officer at the Center for Healthcare Strategies. And before we get started, I'd like to just quickly go over a few logistics. To eliminate background noise, audio lines are being muted during today's event. We can go to the next slide. There will be a moderated question and answer session following today's presentations. You may submit a question online at any time by clicking the Q&A icon, which is at the bottom of your screen. Today's event will be recorded and shared publicly on bettercareplaybook.org, and you'll be able to download the slides and watch the recording, and we'll share the link for you to do so in the chat. And then finally, at the end of the webinar, we'll share a brief online evaluation that will pop up on your screen. We encourage you to complete that, and we really value your feedback. Next slide. So welcome everyone who is just joining us. We know that many people joining us today for this webinar have closely followed the findings from the randomized controlled trial published in early 2020 of Camden Coalition's care management program. And more recent studies have analyzed data from this trial and have uncovered really important findings about the impact of care management for different populations. So today we're excited to dive into the lessons from those evaluations and really learn from how Camden Coalition has evolved its strategies and programs in recent years. So we'll hear insights from a group of Camden Coalition staff on how to tailor complex care programs. We'll learn more about how to identify the populations who are most and least likely to engage, and also discuss what partnerships can help really ensure that care management isn't taking place in a vacuum. So next slide. So here's a quickly walk through the agenda. We'll first hear from the Camden Coalition team, who I'll introduce shortly. Then we're really fortunate to be joined by Robin Golden, who is Associate Vice President of Social Work and Community Health at Rush University Medical Center in Chicago. Robin will share her reactions to the presentation and offer insights on how these evaluations are shaping clinical practice across the country. And then we'll follow that with a moderated question and answer session. Next slide. And for those of you who might not be familiar, the Playbook is an online resource center for evidence-based and promising practices to improve care for people who have complex health and social needs. So every month, the Playbook is summarizing new evaluations, new implementation tools, and journal articles, such as the studies that we'll be referencing today. The Playbook also develops resources like this webinar that are really designed to help translate evidence and research into practice. And you can explore the Playbook more at bettercareplaybook.org. Next slide. So the Playbook is coordinated by the Center for Healthcare Strategies with support from 7 leading national healthcare foundations. Those are Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, the Milbank Memorial Fund, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. Next slide. Next, I'm pleased to introduce today's presenters. So we're joined by 3 staff members from the Camden Coalition of Healthcare Providers: Natasha Dravid, Senior Director for Care Management and Redesign Initiatives, Jessica Cordero, Senior Community Health Worker, and Dawn Wiest, Director of Research and Evaluation. Each of our speakers brings a really unique role and perspective on these questions of applying evidence and adapting new approaches to care delivery. And then, as I mentioned earlier, after the presentation, we'll hear brief remarks from Robin Golden. And Robin is a national leader in the field of complex care and has multiple roles leading initiatives at Rush University Medical Center. Next slide. And with that, I will turn it over first to Dawn Wiest. Welcome, Dawn.
Thank you, Logan, and for the whole CHCS team for the opportunity to share our work today. Next slide, please. Great. I'm sorry, the one after that one. Yeah, so thanks so much again. So my goal today is to share an overview of the research that has been published on the effectiveness of the Camden Core model in reducing hospital readmissions among individuals who have complex health and social needs. And I'm sure a lot of folks on the call today have read all the papers and know these results inside out, but I do want to share some high-level findings from the papers, beginning with the first RCT paper in 2020. So back in 2014, the Camden Coalition partnered with the Abdul Latif Jameel Poverty Action Lab, more commonly known as JPAL, and based at MIT, to conduct a randomized trial of its signature care management intervention, the Camden Core model. Patients who met the eligibility criteria of having at least 2 hospital admissions in a 6-month period, 2 or more chronic medical conditions, and evidence of other complexities such as difficulty accessing services or lack of social support, a coexisting mental health diagnosis, or homelessness were enrolled while they were in the hospital. After discharge, patients who were enrolled in the core model intervention worked with an interdisciplinary team of nurses, social workers, community health workers, and health coaches for an average of 90 days. The care team conducted home visits and coordinated follow-up care in the community, connecting patients to services that were needed, and behavioral health providers, helping patients apply for benefits, and so on, and also coach patients in health strategies such as blood pressure monitoring, blood sugar monitoring, or medication management. Care teams prioritize building genuine relationships with their patients and supporting patients as they strove to achieve their own health goals. For the RCT, the primary outcome studied was hospital readmissions 180 days after discharge from the hospital. Eligible patients were randomized at the hospital bedside into the core model intervention or to receive usual care in the community. There were a total of 800 patients in the RCT, and these were equally split between control and intervention groups. The initial results were published in 2020, and they found no effect of the core model on reducing hospital readmissions. So in other words, patients in the control group and the intervention group readmitted at the same rate, around 62% within 180 days of discharge. So we then worked again with JPAL and the Center for Healthcare the Center for State Health Policy at Rutgers University to study a subpopulation of that full RCT population. And these were patients who were Medicaid beneficiaries. We linked Medicaid claims data to the RCT study data to study more hospital utilization, more healthcare utilization outcomes. So in other words, a broader range of utilization outcomes, such as outpatient visits with primary and specialty care providers, access to durable medical equipment, and pharmacy use after discharge from the hospital. That paper was published in 2023 in Health Affairs, and in between those 2 papers, we published papers sharing results from additional secondary analyses, which I will summarize today. Next slide, please. This slide summarizes the findings from the first RCT paper and the paper that reported the results from the Medicaid beneficiary subpopulation of the full study population. That first paper found that core model care teams were successful at helping patients access Supplemental Nutrition Assistance Program benefits, SNAP. In fact, participation in SNAP was 9% higher for patients enrolled in the intervention compared to patients in the control group. Now, the study that focused on the Medicaid group, the one that looked at a broader range of healthcare utilization outcomes, found that the Camden Core model increased outpatient visits with both primary and specialty care by 56.5% relative to the control group, and that this effect continued for a year after hospital discharge. That analysis further showed that the Camden Core model increased the proportion of individuals who had received any durable medical equipment, including oxygen tanks, wheelchairs, so on, 180 days after discharge by 42% relative to the control group. And my colleague Jess will add a little bit more insight into these findings.
Sure. So the reason for this connection was relationship building. We slowly built relationship with providers and staff so that they were familiar with our team. Our goal was so that we can coordinate care and get things done in a timely manner. So just to give a little example, we had a participant who needed a hospital bed. So we were able to call that primary care office and get a request for a hospital bed. We then had that script faxed over to us, and we were able to get her a bed within a week. So just that relationship building with the office helped.
Great, thanks so much, Jess. Also want to point out that from the two studies, the full RCT population and that subpopulation of Medicaid beneficiaries, the second paper also found no effects on readmission rates and also found null effects for emergency department utilization, access to prescriptions, and the use of home health services. The conclusion from that paper was that because intermediate outcomes such as connections to primary and specialty care were achieved, the core model was implemented well, but care coordination may not be sufficient to reduce hospitalizations within such a complex population. Next slide. Now, after the first RCT paper was published, we asked whether variation in the amount of intervention that patients received may have influenced outcomes. Randomized designs control for regression to the mean by balancing out the patient population on key pre-enrollment characteristics such as age, gender, medical conditions, housing status, etc., so that the intervention and control groups look alike. However, randomization on its own cannot balance out or account for the amount or frequency of intervention received. With a large enough study population, researchers might be able to observe a treatment effect if that effect was limited to a certain subgroup of the study population. Our RCT was not designed to account for any variation in intervention exposure, and therefore was not powered enough to detect a subgroup limited treatment effect. In our reanalysis or secondary analysis of the RCT data, we first studied the intervention group only and found wide variation in the number of hours that the care teams were able to spend with patients during the intervention. There were actually a number of patients who had no contact with the care teams during that first critical week of intervention enrollment. That's the time when a person is released from the hospital and back in the community and adjusting to life again back in the community. It's a really critical time for beginning to build that relationship and building trust between the care teams and the patients. Now, there are other patients who were engaging with the care teams right off the bat. Like as soon as they were discharged from the hospital, they were in the community. Care team members were able to visit them at home. They, on average, had 3 or more hours of engagement that first week. So there was wide variability. So what we did is we then compared readmission outcomes for individuals who were in a lower dose group or a lower intervention exposure group versus those that were in a higher dose or higher intervention exposure group. And we found that those in the high dose group had lower readmissions. Now, of course, we can't make causal claims based on that analysis because we were just looking at the intervention group, and it was a pretty straightforward design, just, does dosage connect to readmission rates? And it did, but we couldn't control for things that we didn't observe. Like there may have been factors at play that both influenced whether somebody was going to engage in the intervention and also whether they're going to readmit or not. So what was important about that analysis and that paper was that it set the foundation for another study of the data in which we utilized a robust statistical technique that builds upon the randomized design of the original study. And this technique, called the distillation method, was developed by researchers at Kaiser Permanente for analyzing data from randomized clinical trials that were underpowered due to low participant enrollment or variable participation levels, which was the case with our RCT. Next slide. So using the distillation method, we were able to compare readmissions for intervention and control groups based on each patient's predicted level of engagement in the intervention. That analysis was published in JAMA Network Open in 2023 in September. And in that analysis, we found that the core model did significantly reduce 30 and 90-day readmission rates and numbers of readmissions 30 and 180 days after hospital discharge. Next slide. This analysis also helped us identify characteristics associated with higher or lower engagement in the core model. So this graph shows the percentage of patients with each characteristic listed down the y-axis within the full study population of 800 patients, which is the gray bar that you see extending out. And then the red bar represents the subgroup with the highest concentration of engaged patients, or 20% of the full population. Here we highlight 3 characteristics associated with lower levels of engagement in the intervention. Patients experiencing homelessness, for example, comprised around 10% of the full study population, but only 4% of the most engaged subpopulation. Those with any arrest in the 6 months prior to study enrollment made up 6% of the full population, but were not present at all in the highest engaged subpopulation. And while patients with a substance use disorder represented 33% of the full population, they comprised 26% of the highly engaged population. Next slide. So a few of our takeaways from these studies was that just looking at the general results, core model successfully connected patients to much needed services and resources in the community. These included outpatient medical care, government benefits, and durable medical equipment. Another takeaway was that the core model can reduce readmissions among individuals with complex health and social needs when it is delivered as intended. But there are barriers to engagement that must be addressed, including criminal justice involvement, housing instability, and unmet behavioral health needs. Moreover, another takeaway that we've talked about quite a bit is that reducing readmissions is not an appropriate or achievable goal for all groups of complex care patients. And a wider range of outcomes must be identified and measured in order to fully comprehend the value of complex care programs. And thank you, and I'll turn it over to my colleagues.
Thanks so much, Dawn. It's been really amazing to have this new data come out. I think folks can imagine in 2020 when the first RCT results came out, and it was a null effect, there was a lot of emotion, there were a lot of questions. So it's really just been amazing to have the opportunity to dig deeper into that data and pull out these additional insights. So we're going to talk now a little bit about sort of what has the coalition been doing since, what have we learned? And we're going to talk both about kind of our work in the care management space as well as clinical redesign work. So what that means is when we talk about care management, we're really referring to that high-touch community-based work, which is rooted in the core model that was studied in the RCT. So we'll talk about some of the enhancements and subpopulations that we've been working with since the RCT. And clinical redesign is the work that we do in tandem with care management in an effort to elevate the standard of care by partnering with our provider community. And these are programs in which the coalition staff have lighter touch interventions directly with patients, or are working with providers and building their capacity to deliver care differently. So we'll talk about both of those as we move forward. Next slide. So even before we had access to the hard data and all of the incredible methodology you just heard about, we had the experiences of our patients and our care teams, which was equally important in how we drove program design. So the major investments that we made kind of as we were in the midst of the RCT and even coming out of it were in our Housing First program and our medical legal partnership. So you saw from the data, housing instability and street homelessness, substance use disorder, and the related legal barriers were some of the most common social factors that were facing our patients. So when our care teams didn't have reliable or sustainable access to these services for patients, we made the decision as an organization to kind of home grow these programs. Our Housing First and medical legal partnership teams really kind of enhance the work of our interdisciplinary care team. So we now have a housing specialist on staff as well as lawyers. And we also during that time brought on clinical social work onto the care team, which we didn't have at the start of the RCT. So I'm going to ask Jess to talk a little bit about that experience of having those care team members added to the team.
Sure. So our care team encountered very many barriers. And when we would have weekly care planning is when we would have discussions on what we're doing with each participant. And we all had in common that we had participants that we were unable to find in a community because they were living with homelessness. So it made it difficult to follow up on our care, on any goals they wanted to work on. And having these discussions with our supervisor and leadership, then that's when we decided that that we needed help with housing. And shortly after, that's how Housing First came about. So having that support for housing for anyone that has a history of homelessness. And then with working with looking for housing, we found that a lot of participants had fines and warrants that would prevent them from getting IDs. that would help for, to get them housing and also approval for housing. And in having this discussion again in care planning, and with leadership, we decided that we needed more support for, all the participants that had the legal issues. And shortly after, that's when, the MLP started. Thank you.
Thanks, Jess. So then another kind of change that we've seen over the past few years is around telephonic engagement. So that first grew out of our clinical redesign efforts when we were trying to do larger scale transition of care programs kind of alongside our RCT. But then also we, with our Accountable Health Communities grant, that was a CMS program, we were doing a lot of screening and navigation telephonically. And then of course, during COVID, we really had to understand what can we do telephonically, what can we do virtually. When I joined the coalition more than 10 years ago, we did not believe in telephonic case management or care management at all. But over the course of COVID, we've learned that there are things that can be done over the phone. We really believe that you can build relationships over the phone. And it's another important skill and tool to have in the toolbox. So that's just another evolution that's come along since then. Next slide. So in addition to the expansion of our care teams to address the needs of individuals with criminal justice and substance use, we also expanded our portfolio to go deeper with these populations. So our Camden Reset, I'm going to talk through some of these and then have Jess give a little more color, but our Camden Reset pilot was an application of our core model that allowed us to begin working with individuals while they were still in the Camden County Jail. So we had a nurse and a community health worker who could go into the jail and begin that care planning process before they came back into the community so that we could really support reentry and the social linkages that they needed in the community. There were a lot of lessons learned from that work. It was, first of all, it took a long time for us to get clearance to get in the jail to really stand up that workflow, but also the needs were just so intense with that population that it really led us into systems level collaboration with our local jail. So we were able to give county jail staff access to our health information exchange so they would be able to see more information about the individuals coming into the jail. They could improve coordination of care and medication management in the jail. We also have now jail clinic data in our HIE, so providers on the outside can see what's happening with their patients when they are in the jail. And then finally, we've been really digging into building better pathways for patients who start medications for opioid use disorder in the jail and supporting those transitions back to the community so they can connect with addiction medicine providers as soon as they are re-entering the community. So Camden Delivers was a pilot that we ran almost at the same time as Reset. And this one was focused on high-touch community-based care management for pregnant individuals who were living with substance use. And Jess was our community health worker on that program. So I'll let her share some of the lessons learned from that program.
Sure. So with Camden Delivers, there were many barriers that we faced. We had moms who just didn't have trust in the system. Moms who thought that we were working with the child welfare system, so they were hesitant to sign up with us, thinking that we would be a waste of time, that we couldn't make a difference. And just moms being so busy, not having time to work with us, because when they're working with the child welfare system, they have a lot of requirements. And so it's hard to fit in extra stuff. But knowing that we were working with moms with a lot of trauma, we took time to build that trust, and we did that slowly. And one of the key things that how we were able to build this relationship was being transparent and always showing up for them.
Thanks, Jess.
Mhm.
So I know we're a little short on time. So next slide, I think I'm going to skip this slide and just move on to, this is really exciting for the policy wonks, but I think we'll move forward one more. Great. So I think one of the biggest evolutions that our organization has really seen from the start of the RCT until now is really crystallizing how we think about ecosystems of care. So our internal takeaway from 2020, from those initial null results from the RCT, wasn't that high-touch community-based care management doesn't work to reduce hospitalizations. What it really taught us is that we need systems change to happen in tandem with high-quality programs. So if you think about care management by itself, right? Care management by itself is walking alongside patients and supporting them in learning how to navigate a broken system. An ecosystem approach is more about saying our patients' experiences are shining a light on exactly where and how the system is broken. So let's build partnerships, let's redesign workflows, let's change policies to start to repair the places where it's broken. And let's use organizational relationships, data, and community voice as that connective tissue to help us strengthen those ecosystems. So this slide shows some of our current portfolio and examples of how we're working across patients, providers, payers, and policymakers, which I'll start with P, to really think about this ecosystem of care. So starting at the bottom is really that high-touch patient-facing work, and I will just highlight a few of these examples. So eviction prevention is a pilot that really started to emerge when the eviction moratorium ended and landlords who maybe hadn't been able to collect rent for several months started to really ramp up eviction proceedings. So our care teams came to us and said, we're seeing all these housing barriers, but they're not the same housing barriers as before. These are individuals who have fallen behind on rent, have never been at risk of homelessness before, but there's suddenly this larger population of people who need help and need to pay their back rent and just need some financial support to get back on track. So we were able to stand up a pilot, which was a collaboration between our care management team, our medical legal partnership, and our finance team to figure out how do we stand up this operation to pay back rent and utilities in conjunction with our other services. In the second tier, we're talking about larger scale transitions of care pilots. So an example is our Safer Childbirth Cities work with, this is with individuals who we are observing enter the emergency room, are pregnant, but have not yet been connected to prenatal care. And so we worked for 2 years to really stand up outreach workflows with OB sites to call those individuals within a few days of their ED visit and really invite them into pregnancy care, whether that's prenatal care, if they're experiencing a miscarriage, support for that, if they're looking to access abortion services, and then any other social needs that were coming up. So that is a larger scale. You can see that we were monitoring across 13 emergency rooms, but that was a lighter touch intervention that really was in partnership with our provider community. And then finally, in that top line, this is where we're really thinking about complex access barriers that affect patients, but are dependent on the interplay of provider processes and payer policies. So quickly, the Sublocade example, Sublocade is an injectable form of buprenorphine, which is often dispensed through specialty pharmacies. So there's a lot of policies on the back end that are so boring to talk about, but that create these really inequitable barriers, particularly we've observed for individuals on Medicaid. And so we've been doing a lot of work with kind of playing that role between our providers and the managed care organizations to say, what can we do to really relieve these inequities? Next slide. So where we're heading, I'm going to try to go so fast. If you go to the next slide, we're really thinking about how all of this work comes together, right? So regional case conferencing, this is work that's grown out of our focus on behavioral health and trying to identify that very, very, very small number of individuals who are frequenting multiple emergency departments. And in our case, who are frequenting all of the health systems in our region. So we recently did a data poll that showed us that in the past 6 months, there were 12 individuals who had frequented all 4 of our health systems. These are folks with so much complexity, so much going on. We really believe there's value in bringing together these interdisciplinary teams across the region to really understand where is the system failing these individuals. Next slide. We're also investing really deeply in workforce development. So our care management work is never going to be wide scale, right? We're never going to try to scale just the number of patients that we, the coalition, are working with. One of the ways we do want to scale is capacity building and taking our experiences and putting that into curriculum that can reach all kinds of frontline providers. So we're very excited about our complex care certificate, which has just recently launched. And we're making that available as it's nationally available, but really we're trying to make that even more accessible for folks within the South Jersey ecosystem. Next slide. This is the last thing that we'll talk about quickly. So we often get the question, right, coming out of the RCT, if cost and utilization aren't the things that we should be measuring, what should we be measuring? So this is a snapshot of the framework that we've developed internally that we're really trying to use now to evaluate our own work on what are we doing to strengthen ecosystems of care. So to me, this slide is about 10 years ago, we had that slide that showed a patient in the middle and all the social needs around them and how only 2 of them were medical. This is sort of the evolution of that, which really in this slide, there's all these domains and there's only one little square in there that's about whole person care management. So really it's about all of the systems that surround our care management programs. And if you quickly go to the next slide, you can see we're not trying to work on all of this at once. We are really saying for each of our programs and pilots, where do we hope that we're making impact, choosing those domains, and then really working through, we have actually a whole framework with attributes and measurable, what do we call it? A maturity model rubric that helps us kind of scale where we are. And we do that in partnership with any of our provider partners who are working on this with us. So I will stop there. I think I went way over and turn it back over to Logan.
That was a wonderful presentation. So thank you so much, Natasha, Jessica, and Dawn. We're fortunate now to be joined by Robin Golden to share her reaction and response to the presentation and kind of her thoughts on how to apply lessons from these and other evaluations of complex care. As I mentioned, Robin is the Associate Vice President of Social Work and Community Health at Rush University Medical Center in Chicago. So welcome, Robin.
Thank you, Logan, and thank you, CHCS. It's a privilege to be here today to have the chance to comment on your contributions, both to the field and the overall need that we in the complex care arena feel every day. The RCT and the deeper analysis you've done looking at dosage and who you intervene with has helped us better understand the importance of challenging the assumption of the null result at first actually means no impact. So it's so easy for us to run from that when we hear it, and you didn't do that. And also the notion of regression to the mean, that it's the only reason that some people's outcomes may have improved, is also a challenge that you've taken on in terms of your research that I think will have great contributions. Your further analysis, your further evaluation helped us better understand that you did indeed see an impact in those whom your stellar team engaged with, while at the same time highlighting the need to build stronger ecosystems. For example, as you highlighted today, you found that patients who received a relatively higher dose of the care management intervention had lower hospitalization rates at 30 and 90 days post-enrollment compared to patients who received a lower dose of the intervention. It's important that we look at innovative ways to understand our value and impact. We're challenged about it all the time, and not let the traditional ways of understanding outcomes limit us from conducting secondary analyses to maximize our learnings from the data. It's too easy to let the research police write off our findings. We are seeing this leadership in the government as well. The Administration on Community Living is revisiting how it reviews and defines evidence-based programs to be more inclusive of diverse communities and settings. And even the NIH is supporting an arm of pragmatic trials that take place in real-world clinical practice settings. This is what we need to fight for. A recent piece on the Better Care Playbook does a great job talking about the imperative for complex care to not take null findings at face value when factors are in play that lessen statistical power of the analyses. Factors such as losing many participants to follow-up, which we know is unfortunate, but prevalent in our intervention as we outreach and try to engage individuals with complex care needs. Your pushing has made a difference in this field, and I applaud you. Part of our struggle in the field of complex care is that we have not done a good job studying the value and impact of relationship. I commend you for trying and focusing on authentic healing relationships. In our model, our Center for Health and Social Care Integration care model at Rush, we emphasize creating a therapeutic alliance with the patient or community member who we are working with, and know there's a lot we could study there. We need to all study that more and hopefully study it together. The team at Siren out of UCSF published a recent piece in Millbank Quarterly showing the evidence suggesting that emotional support has an impact on health and healthcare utilization as part of community care interventions. This is why co-design with the people with lived experience is critical as well. And I love that you're utilizing goal attainment scaling more in an attempt to hear that person's voice. An ongoing challenge we know is that the metrics we are looking at don't tell the whole story, and evaluations are hard to make conclusions from when there are other things happening. For example, in the CMMI Community-Based Care Transitions Program, CCTP, we demonstrated that we tested a model from hospital to home of transitional care with community-based organizations in the driver's seat in a new, innovative way. And again, even though we showed changes nationally in this data, the project and the program was not necessarily viewed as a success. So how do we get to the bottom of that? And it's unfortunate because, as we know, there are many people that felt helped by that program, yet it gets disqualified as a leader. And as a practice leader, it's hard to be working toward quality goals and to effectively reach them in the claims data we saw, but still to be told that our program hadn't ultimately demonstrated the impact was hard. So that's the stuff we need to be able to turn around. Also in the CMMI accountable health communities, as you mentioned, your work that care management and navigation are not enough alone to improve people's outcomes. This is true, this is reality. In AHC, evaluators found that program staff, community service providers, and beneficiaries described challenges connecting beneficiaries to community services. That's why your attempt to create MOUs with other CBOs and other experts in the field make a lot of sense in terms of creating those bridges. At Rush, we're continuing to struggle with some of this. We're trying to both deal with the micro, the individual that we're helping, as well as the macro, trying to create systems change. And we do that all the time. Today's important community care hub movement expands on the spirit of collaborations that reinforce both the safety net and the continuum of care. As community care hubs roll out across the nation with leadership and support of the Administration on Community Living, it will be great to see what we learn about best practice and impact. So we look very much forward to that. And all of this work, which you really need to hold on to, has influenced policy and payment. The physician's fee schedule that just came out in January shows greater attention to our work around social care, around the whole person care, seeing people as more than just their disease, seeing interventions as more than just a procedure. This is critical, and that's why your work, your evaluation work, and your clinical work can influence policy. Thank you for the opportunity to share a few remarks today and to applaud the Camden Coalition team and evaluation partners' work and leadership. I look forward to the audience discussion.
Thank you so much, Robin. We so appreciate your remarks. really based on your leadership and expertise in this work. So thank you again.
Thank you.
So we are getting a lot of great questions, and we also received a lot of wonderful questions earlier. And so we will do our best to get through as many as we can. First, we received a few different questions that kind of ask what the evidence from these studies tells us about the overall effectiveness of care management programs, including on the question of total cost of care. And so I'd love to hear your perspective on kind of how to speak to that question of what these studies and your work have really taught about how different populations respond to care management and how to consider the impact on outcomes such as changes in costs.
Sure, I'll start with that question. I think my colleagues will have a lot to say about that too. The first thing I want to speak to is the fact that I really believe that we're just at the very beginning of building an evidence base. I mean, there've been a number of studies over the years for sure, and I would say that some of the main takeaways from those studies are the importance of understanding your population and the extent to which your intervention is finely tuned to the needs of that population. And a lot of these studies have focused on programs with very narrowly defined populations. So for example, I think about Mary Naylor's model, the RCTs of that model, which showed really great results in terms of effectiveness in reducing readmissions and therefore the cost of care. That group of patients was far less complex than ours, for example, and the eligibility criteria for entering into the intervention was much more narrow. So I think so far what the evidence is showing is a need to be very careful about the outcomes you're trying to measure and understanding fully like what the needs of the population you serve are and the extent to which your intervention is able to achieve the outcomes that it strives to achieve. So I know that's not like, a very specific answer in terms of total cost of care, but I think so far that's what the evidence is telling me.
Thank you so much, Dawn. And there's a few questions I think that are nice follow-ups to that. The first is, what outcome measures do you think are really important to center to really understand, the overall impact and success of the coalition efforts?
Okay, I'll take that one. I'll start with that one too. Robin mentioned something really important, which was like the value of the importance of measuring relationships and the value of relationships and the ability to build really genuine relationships with the people that you're serving in an intervention. And I think with that, like for the Camden Coalition, we've always prioritized that relationship building aspect as well as prioritizing the self-defined or patient-defined goals, health-related goals. So I would say that being able to understand and study that relationship building piece and the extent to which that relationship facilitates the ability of patients to achieve the goals that they set for themselves in terms of health and wellness is really critical. And to that end, we worked with as a collaborative to pilot person-centered outcome measures and really learned a lot through that. So I would say that it may be the case that there is no one outcome measure that's appropriate for every intervention. And that I know that there's often like a little bit of tension between what patients and programs think are important to measure and what payers and hospital systems think are important to measure. So somehow beginning to align that so that we are able to measure what we think is most important and are able to fund efforts to measure those things that we think are most important is really an important next step.
Thank you so much. Really appreciate your thoughtful and nuanced answers on those. One question that just came in asked, well, it notes that your findings point to the importance of optimizing patient engagement with care management services. Could you speak to any lessons that you've learned or practices that you've adopted to increase the number of patients who accept services?
There we go.
Yeah, so when I think about how we try to increase outreach, we started with telephonic, and then we also what works best is going to the hospital bedside. So we have a team that sends us triage daily, and we will go straight to the hospital and have these conversations with participants and explain our services to see if they would be interested in working with us. And basically how I word it is that, you know, we work on whatever goals you want to work on. We don't set the goals for the participants. And then we go from there. And then we hope that we can engage them in it once they're in the community. That's the other challenge.
Yeah, and I'll just add, I think one of the projects we're working on right now is a hypertension pilot, which sounds, you know, really kind of clear, straightforward, but what we're learning about that work is we're leading with relationships, we're leading with what are your goals. You would assume that people aren't necessarily like, my number one goal is to, you know, fix my hypertension. But what we're finding is that there is a lot of engagement around blood pressure management, like as the care teams go in and start those conversations. So I think we're really also interested in like, how do these things go together? These metrics that are really kind of important to payers or providers, and how do they intersect with a patient's goals for themselves and their quality of life? So I think there's a lot to kind of dig into there.
Thank you both so much. So there's a lot of other great questions, and I'll just note if you'd like to have your question answered, you can click on the Q&A icon at the bottom of your screen. We've also we received some really interesting questions about partnerships. So one question asked what some of the partnership challenges have been that you've experienced, especially between the healthcare and social service sectors, and can you speak to some kind of high-level strategies for addressing those challenges?
Sure, yeah. So one of the ways I think about this and talk about this sometimes is that there's a real parallel between the way we do our work with patients and the way we do our work with partners. So during the RCT, one of our key performance indicators was the care team had a goal of seeing a patient face-to-face once a week. Really because we saw that measure as a proxy for that relationship building. On our clinical redesign team, we have sort of a similar rule of thumb where we are meeting with partners once a month. We have this like ongoing sort of engagement with partners, whether or not we're in sort of an active pilot or workflow with them. We really take those relationships seriously, and you know, we keep it up. So I think it's about that foundation, not just going to partners when you need something, but really, you know, being able to work those relationships kind of in real time. So we do a lot of showing up to provider offices with donuts and coffee. We do a lot of just trying to show up for other people's initiatives. And I think that that's part of it. I know Jess has like some examples from a care team perspective of how these challenges have showed up. I don't know, Jess, if you want to talk about that.
Sure. So the challenges that we faced in the community, I would say for the providers or the offices that didn't know the Camden Coalition, is getting access to appointments. That was a big thing. Not being able to accompany patients to their appointments per the provider. We had a couple providers that were a little hesitant on having us in the room with the participants, which was a challenge. Lack of communication sometimes regarding meds between PCP and specialists, limited behavioral health providers. That's always been a challenge, anything with behavioral health. Transportation to appointments has always been a barrier. They get to their appointments late and it's an issue. long wait times to apply for benefits, and there's always been issues with limited beds in the shelters.
So a lot of that can be addressed when you have these ongoing relationships more at the on the administrative level or at the leadership level. I think we also see sometimes like just values misalignment, and there's an opportunity, I think, over time to model, to show up, to like really kind of be patient when there are maybe, you know, areas where we don't see exactly eye to eye with partners, but we don't give up and we keep trying to work those relationships.
Thank you so much. And I'll just note that we're getting some great questions, including I think questions that relate to resources on relationship building, resources on person-centered outcome measures. We'll share a follow-up email with everyone participating and share some resources that from the playbook, and we'll coordinate with Camden just because we know that there's a lot out there that we hope can be really helpful and supportive for everyone who's kind of doing this work in different settings. One other, you know, you all mentioned the shift to do more telephonic work. And one question we got was asking about what insights you have about virtual care delivery when thinking about patients with complex needs. So Jess, I'll invite you to speak to that question.
So instantly I think about the challenges that we faced with telephonic, just because we were doing face-to-face visits. So we had, a big homeless population who were experiencing homelessness, and they didn't have phones with video capabilities to actually do these visits. So naturally they would just go to the hospital to be seen because they wanted that face-to-face. Or we would have participants who didn't have internet access to actually, connect. We also found out in these calls that we had like an elderly population who weren't tech savvy and couldn't figure out certain things. So a lot of challenges. So it made it difficult to connect to a lot of participants when you try to do the FaceTime. So we just try to make the best of it. Yeah.
So, and I think that's really that's that super complex, high touch, community-based care management, like that population where we really value the in-person engagement. I think we've found in some of our other, our lighter touch initiatives, there are populations and specific kinds of initiatives that you really can move forward with telephonic. And I think our prenatal care initiation pilot is a really good example of that. We're seeing a higher than 50% contact rate for that one. And we think that there's a few things we've learned about that, like getting in touch with that person, the phone call coming soon after an ED visit. Patients see that as part of that episode of care, and they're not as weirded out to get a cold call around it. So I think we're feeling out where are the places that we can leverage technology in different ways. And we also have large scale Medicaid redetermination, right? That's one where, we have to figure out how to reach patients. We haven't done as much with the actual care delivery, like on tablets, telehealth, as much with our work, but I think there's a lot to learn there as well.
Thank you. So we'll get to, I think we have time for a couple more questions. Another question was kind of addressing some of the policy challenges and asking what are kind of funding sources that you found to address health-related social needs within clinical settings, and how, can you kind of share any insights about how participants can think about, looking for opportunities that might be available?
It's a great question. I think, the big accountable health communities initiative through CMS, we're all really excited about, because it feels like that the data collection that was done through that screening for social needs and navigation could potentially lead to more funding for the actual services. That grant didn't come with any funding for actually paying for transportation or paying for some of these services. So I think that, you know, keeping an eye on the policy conversation is important. For us at the Camden Coalition, that was a slide I skipped. We used to be a Medicaid ACO where we were trying to figure out, you know, cost of care. How can we like learn from the Medicare side and apply that to Medicaid? But what we found was translating that into our regional health hub model. And I think there are others of these across the country where New Jersey has said, okay, a regional health hub is an entity that can really help us with convening and with data and with just being a thought partner for program design. So we do receive funding through that mechanism, and that has opened up a lot of opportunities for the state to say, these are priorities that we have, and the regional health hubs are a vehicle to work on those initiatives. And that often includes sort of the social care aspect as well. But it's a tough, the way in this country that we don't necessarily invest on the social side is, I think we're all just feeling that in different areas of the healthcare world.
Thank you so much. So I think one last quick question, an interesting question that just came in, kind of as you think about the kind of how to think about a structure and a design that would work best for people with behavioral health conditions. And Jess, maybe this is a question for you of, you know, if you could have the question asks a psychiatrist, psychologist, or therapist available to, you know, you and your clients, how would you design that system and what would be most helpful to your teams and patients? And I wonder if even broadening that question to just ask, you know, kind of any lessons for specifically how to address the needs of patients with serious behavioral health conditions. And yes, Robin, thank you for adding in social worker. I think thinking broadly about the workforce, perhaps bringing in peer providers as well, would just kind of welcome your comments about thinking about that, you know, population in particular.
Sure. So when I think about like when I'm doing an intake, right, and we go to the behavioral part, and depending how they answer, whatever the case may be. But if they answer something where, let's say, if they're living with depression or if they have suicidal ideation, it's always hard to find a provider, like especially if they're Spanish speaking, that will see them right away. That's always been our struggle. But as far as like our team, we have a social worker that we refer to, and we will send her an email or we will call her right at the visit if we're having a situation that we're unsure on how to handle. And that's how we get our support. So we are very thankful that we have our behavioral component in our team. But for us, it's always once they're no longer with us, that's where we struggle trying to find that handoff and that support with behavioral health. And it's always been that way or if they have a provider that they just don't click with and then trying to find them another person. But Spanish speaking is also always the biggest barrier with behavioral health. If we could have that in the team, like that would just be ideal. Between that and anything with, like the help with addiction would be key. I'll wrap around for everything.
Well, on that note, we'll wrap up the Q&A and just share a few more slides before we close the webinar for today. We just really appreciate all of the insights that everyone shared today. We'll encourage everyone to, if you have established a promising practice in your work, if you've published any research or evaluations, we welcome you to submit those to the playbook. And we'd love to share that information with a broader audience. We can go to the next slide. As a reminder, we ask that you fill out the evaluation survey that will show up on your screen at the end of the webinar. We really value that feedback. Thank you again to Dawn, Jessica, Natasha, and Robin for sharing all of their insights and experience today. Thanks to the Seven Foundation Collaborative for supporting the webinar. And thanks to everyone who joined and shared your great questions. We will be sharing some follow-up materials within the next few days, including a recording of the webinar. You'll have a chance to download the slides. And we welcome any further questions that you may have. Thanks again and have a great day, everyone.